Hi, I'm Dr. Laukkanen, and I'm going to be talking about non-invasive breast cancer, or DCIS. And you may be watching this because you have an appointment with me, and that's great. And of course, we'll be able to go over any questions that arise when we meet. Even though our focus is going to be on the DCIS itself and treatment decision making, this really is all about you. That your general health and your preferences are going to be the key drivers of what happens to you. A few words about in situ breast cancer, the best kind. And as you can see, 98% or so don't have any issues with cancer related to this 10 years down the road. So if one has to have breast cancer, non-invasive breast cancer is the kind to have. Our focus when we say DCIS is that we're not talking about lobular carcinoma in situ that you might read about, and we're not talking about DCIS when it's mixed with an invasive cancer. And here our focus is on those cases which have been managed with a lumpectomy or breast conservation. So DCIS is often found on a screening mammogram. Here's an example of a report showed a little 6 millimeter density in the right breast upper outer quadrant. Or it might show up as microcalcifications. These are almost little like grains of salt on a mammogram, and you can see there's a little cloud of grains of salt if you look closely at the arrow and well beyond it. What's actually happening with DCIS? How is it being formed? And here we look at the structure of the breast, which was built for milk production and transportation. So a set of little sacs or lobules where the milk is produced, and these transport tubes are ducts that traverse almost like little branches to trunks out to the nipple. And if we look at those specific structures, that's where breast cancer gets its first footing. Normally, the ducts are lined with a neat, regular layer of cells. And for reasons that we don't fully understand, those cells can start piling up abnormal numbers, abnormal forms. If they're abnormal enough, that's breast cancer. And the difference between DCIS, or non-invasive cancer, and invasive cancer is that in the non-invasive, or DCIS, the cancer cells are all confined inside the walls of the ducts. Whereas in invasive cancer, the cells are outside the walls as well. And it turns out that these duct walls they don't offer a real mechanical barrier. They're flimsy, thinner than the finest tissue paper. So if the cell has the biological ability to live outside the walls, it does. So DCIS is really an earlier, less biologically advanced and more confined form of breast cancer. So a person, if they've had an abnormal finding, especially on imaging, mammogram, ultrasound, and so on, typically proceeds to a biopsy. And the biopsy would typically say this is non-invasive in the sample that they see, and they'll comment likely on what's called the nuclear grade and rate it low, intermediate, or high. And if we look at where does that all come from, cancer cells in non-invasive cancer indeed are divided into those groups, low, intermediate, and high, on the basis of a few features. And the pathologist looking under the microscope will look at the size and appearance of the structures in the cell, how they're organized, and if there's a lot or very few dividing cells. And as you might imagine, the low nuclear grade is a more easygoing thing, and the higher nuclear grade is one that is approached with a tendency to more active management. So the surgery itself is often done with some kind of localizing approach because these things often can't be felt as masses, and a tissue segment's removed. And in the picture there, we see an example of a wire localized segment taken out of the breast, and it is that which the pathologist looks at to characterize what's going on. And the report will typically say that there's a non-invasive cancer, and it might describe a pattern. It might say solid or cribriform or papillary, something like that about the arrangement of it. And they'll say high or intermediate to high or low to intermediate, etc., nuclear grade. And they'll typically give the size often in millimeters. And importantly, they'll look at how close did it come to the edges. And ideally, we'd like to have it completely removed. And ideally, we'd like to have a couple of millimeters of margin, if we can get that. The pathologist will comment on whether there is or isn't a thing called necrosis. And there the idea is that especially in the intermediate and higher nuclear grade, the cells pile up in those ducts, and there can be enough of them that the stuff in the middle breaks down, and that breakdown is called necrosis within the duct, so-called chemotonecrosis. So example findings in summary, you might say a 2 centimeter intermediate grade ductal carcinoma in situ with no evidence of invasion and margins clear by 5 millimeters. So that's something that we might start with. There might be comments on, what about the surrounding breast tissue? Is it all ordinary? Does it have benign fibrocystic change? Or can it have one of these potential runners up to cancer, the so-called atypical? And atypical hyperplasia means that there's cells building up. They're not abnormal enough to call them DCIS, but they don't look quite right. So after surgery, one consideration is, well, should we do something else? After all, we've removed the detectable abnormality. And there are really a couple of broad choices. One is to have radiation treatment, and especially if it's a low risk, one can look at observation alone. We're going to go over a few other points as well, but let's look at this to start with. And low-risk cancers, DCIS, might have low nuclear grade or just bordering low to intermediate. They might be small, especially if they're smaller than a centimeter. They might be removed with a nice wide margin, say as much as a centimeter, and none of that necrosis being present. And depending on the patient factors, that might be a very reasonable case to say, well, we're done here. We don't need to look at radiation. So in general, radiation is used in breast cancer treatment, delivered to the breast in a situation where the visible cancer is gone, but there's some chance of having microscopic cells left behind, and that those microscopic cells might cause trouble down the future by growing or potentially becoming invasive. And what we know is that when DCIS does recur, about half of them are invasive. So that's what we want to try to prevent. So radiation treatment is designed as an insurance policy that lowers the risk of a recurrence, and specifically an invasive recurrence. And what it is high energy X-rays that are able to inactivate a lot of, not all, but a lot of types of cancer cells, and especially breast cancer cells. It's delivered from a machine that looks like this. And to plan radiation treatment, there's a careful design process. A person comes for a special scan, and a lot of measurements are taken. And the design work is individualized to the patient's anatomy to get a uniform dose of radiation just where we want it. But the principle is simple. When the whole breast is being treated, the radiation is essentially skimming across the breast. If we look in more detail at the design, we can see that the skin, the breast soft tissue, and a little bit of the rib cage and a tiny bit of the underlying lung tissue are included in that kind of radiation design. It used to be that all of these breast radiation treatments would take at least 3 weeks, but today, for both in small invasive and small DCIS, for the average person, 5 treatments to the breast is considered the more common and standard way of doing things. And under certain circumstances, depending on patient factors and or small margins taken around the abnormal area, an additional 5 treatments can be added. So, up to 10 sessions of radiation treatment. Now, radiation has side effects because, of course, it's normal tissue that's being treated, and it reacts. And for a typical person, there's not too much in the treatment week, or maybe even the next week, maybe a little skin redness, a bit of tenderness and swelling, but afterwards definitely some tenderness, fullness, skin changes that, depending on the baseline pigmentation, whether it's more pigmented to start with or not, the skin can be more tan, pinkish, reddish, dry, peeling, a lot like a sunburn evolves. And particularly for a person that has a larger breast, And where there's friction zones at the lower margin or where the breast rubs against the upper inner arm, there can be more skin irritation. And the more breast tissue that's dependent, the greater the tendency is to have that swelling. Now, importantly, those side effects that I've described gradually settle over a few weeks. And if we look at the long term, and here we're thinking about many months and many years, some people can have some persisting tenderness or fullness, or they can have some shrinkage or distortion of the breast due to the combination of the radiation and surgery. And in big studies, up to 14% have some of that if you look at the 10 to 15 year time frame. And as far as any lingering tenderness, it gradually typically gets less. Maybe about 1 in 10 can have that. Now, during the treatment itself, some people can have a less energy, and that depends on the person, depends on their lifestyle, and a whole host of other factors. And certainly coming to a hospital setting every day, 5 days a week for a treatment, and that's tiring in and of itself. That typically resolves over a period of a couple of weeks. Now, what about any uncommon, delayed, or rare risks of treatment? And I'll just go over what tissues are being covered. We mentioned skin and soft tissues, the rib cage, that little bit of lung. And on the left side, the heart is just below the chest wall. And happily, late effects on the ribs and lungs are of the order of 0.5%. And here we're thinking about having some little scar tissue form in the lung or fragility of the rib or pain that goes with that. So in 1,000 cases that are treated, there might be 5 that might experience that. Now, as far as the heart is concerned, that's been a subject of a lot of interest and controversy. And when we look at the current techniques of treatment, where there's a very specific set of steps to avoid the heart, again, we find that whether the right side or left side is treated, you can't really see any difference between events like heart attacks or heart failure years down the road. And so the thinking is that the modern techniques are largely protective of the heart. When we think about second cancer risks, and any radiation has the theoretical capacity to cause cancer, while that's reported, the risks are very low. It can be difficult to pin numbers down, but the biggest risk is to people who smoke and who continue to smoke, that their risks of lung cancer could be discernibly higher. But the overall lifetime risk, this so-called radiation-induced second malignancy, has been roughly characterized at 1 in 1,000. And for most people, they obviously don't see that. And the reality is that anyone who's had cancer can have cancer again. And it's thought that for those people who do have another cancer event, no more than 3% could be linked back to their radiation treatment. Now, what about treating less than the whole breast? And certainly it's true that for better, smaller DCIS, certainly partial breast radiation is a consideration. And again, if it's appropriate for a patient, that's something that is put on the table. That's where we only treat the zone around where that original problem was found. Now, why go to this trouble? What would be the benefit of the going through 5 days or potentially 10 days of radiation and having this sunburn, swelling effect on the breast and so on? Well, as we said at the beginning, it's lower the risk of the cancer coming back. And the one way to think about the reduction is that it doesn't take away the risk completely, but whatever the baseline risk is, that it reduces the risk by at least 50%. So if the risk was 25%, maybe 10 to 12% over the long term if the radiation is given. Now that risk can be reduced even further. There are certain medications, you may have heard of them, tamoxifen, arimidex, and so on, that affect the hormone environment of the body and how it interacts with cell systems. And those are shown to to make it less likely for new cancers to get a footing. And so we see an even lower risk if those are added. But whenever we add any treatment, it's a matter of weighing risks, benefits, and of course, the side effect profile differs from person to person. So there have been traditional ways of measuring an individual's risk, and then there are some newer ways that are still being studied. I'm just going to talk a bit about those. So over the years, different uh, risk estimators have been developed, and one of them is the so-called MSK, or Memorial Sloan Kettering. And there, one puts in the age of the person, the size of the tumor, the nature of the nuclear grade, and a few other things. And it gives you what is your risk of recurrence at 5 and 10 years without treatment, if you add radiation, if you add radiation and hormone treatment. And if I'm seeing you in consultation, I will be sharing those numbers with you so you can see what the actual measures of benefit might be. Well, there are newer ways, and there's, for example, a molecular way of looking at the cells and looking at how the cancer cell's genetic machinery is put together. And those features can be a marker of behavior and potential marker of treatment benefit. There's one, for example, called Oncotype DX for DCIS. There's a clinical study in progress looking at the merits of that. And the idea is that if people have kind of a low score, that rather than treating them with radiation, that they're observed, and the study looks at how do those people make out over time. So that may be something you'd be introduced to. And again, we talked about non-invasive cancers of such low risk that you could just leave the radiation on the shelf. And patient preference is important in addition to the favorable features. And that's something that can be discussed. So alternatives to radiation apart from doing nothing. One, there are certain cases of DCIS where, in fact, removing the breast is a good idea. And it can be where the DCIS ends up being much bigger than meets the eye, where margins and margins are taken. There's always still at the margin, so it ends up being really big. Another alternative to radiation is to say, well, I'm just going to, I want to take those pills and I'm going to rely on those pills. And if it happens to come back in the breast, I'll cross that bridge when I get to it. So if a person goes ahead with radiation, they have their scheduled visits, they see their doctor once or twice during that treatment, and afterwards, usually the family doctor coordinates a long-term surveillance. And the idea is that because there's no treatment that removes risk completely, that you continue with some form of long-term surveillance kind of indefinitely. So thanks very much for your interest in this. It's a lot of ground that we've covered, and as I say, questions can be taken at your visit to see me if that's something that's on order. Thanks a lot for your attention. Bye-bye.